Important safety information for Aggrastat, tirofiban hydrochloride injection. Indication: Aggrastat is indicated to reduce the rate of thrombotic cardiovascular events, defined as combined endpoint of death, myocardial infarction, or refractory ischemia, repeat cardiac procedure in patients with non-ST elevation acute coronary syndrome. Contraindications of Aggrastat include a known hypersensitivity to any component of Aggrastat, a history of thrombocytopenia with prior exposure to Aggrastat, those with active internal bleeding or a history of bleeding diathesis, major surgical procedure, or severe physical trauma within the previous month. Warnings and precautions. Aggrastat can cause serious bleeding. Most bleeding associated with Aggrastat occurs at the arterial access site for cardiac catheterization. Minimize the use of traumatic or potentially traumatic procedures, such as arterial and venous punctures, intramuscular injections, nasotracheal intubations, etc. Concomitant use of fibrinolytics, anticoagulants, and antiplatelet drugs increases the risk of bleeding. If bleeding cannot be controlled, discontinue Aggrastat. Thrombocytopenia, discontinue Aggrastat and heparin. Bleeding is the most commonly reported adverse reaction. For additional information about Aggrastat, please refer to the full prescribing information. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088.
Hello, everyone. My name is Kevin Ariani. I'm an interventional cardiologist, mostly practicing at Dignity Northridge Hospital Medical Center, as well as Providence Cedars-Sinai Hospital and West Hills Hospital. I am the cardiovascular line director at Dignity Northridge Hospital. I'm here to present case of using Aggrastat for an acute coronary syndrome patient who was not adequately preloaded with an oral antiplatelet medication. Purpose of this video is to demonstrate a typical use of Aggrastat for fellows and those who might not be familiar with contemporary use of 2B3A inhibitors. Here are my disclosures. I received financial support from Medicure for creation of this video. Here is the patient's presentation. This is a 69-year-old female with an existing history of coronary artery disease who was brought into the cardiac catheterization laboratory electively. We performed a coronary angiogram. The lesion in LAD appeared and judged to be significant. Despite that, we performed IFR measurement of left anterior descending artery, and that equated to 0.84, hence a significant flow restriction. In light of severe calcification, a decision was made to proceed with rotational atherectomy. Patient was fully heparinized, started on 25 microgram per kilogram of Aggrastat bolus and 0.15 microgram per kilogram per minute of Aggrastat drip. Before describing next steps, I want to point out that the problem with oral P2Y12 inhibitors is that they take several hours to reach therapeutic levels of platelet inhibition, even for ticagrelor and prasugrel. This is pharmacological data from 24 high-risk ACS patients undergoing PCI. Aggrastat or tirofiban hydrochloride is a reversible antagonist of fibrinogen. It binds to the glycoprotein 2B3A receptor. At that point, it blocks the final common pathway to platelet aggregation. Aggrastat has a 2-hour half-life, and platelets return to normal function within 4 to 8 hours after you stop infusion. Aggrastat provides very potent and rapid platelet inhibition, with 96% of the platelet inhibition occurring within 10 minutes. And Aggrastat has a very consistent response for patients, with 73% of patients reaching greater than 95% of inhibition at 10 minutes. I have to mention that ACC, AHA, and SKY guidelines provide a class 1A recommendation to use a GP2B3A inhibitor for non-ST elevation or acute coronary syndrome patients undergoing PCI who are not adequately pretreated with clopidogrel or ticagrelor. Back to our case, here's how we proceeded and decided to treat this patient. We performed atherectomy using rotational atherectomy. Following that, the lesion was dilated with a 15 millimeter by 3.0 non-compliant balloon. And after this preparation, a 38 millimeter by 3.0 synergy stent was easily introduced and deployed, and the proximal portion of the stent was overexpanded using a 3.5 non-compliant balloon. Following that, an angiogram revealed excellent angiographic result and TIMI 3 flow with the fact that we did extensive atherectomy. Ultimately, patient had excellent outcomes after the procedure and was discharged home. So here are some takeaways from this case. Aggrastat IV bolus and infusion allows for rapid and potent antiplatelet action in situations where there are no or inadequate platelet therapy. Aggrastat IV infusion time can be modified to allow transition to oral antiplatelets based on the patient's ability to take in oral meds at the time of the intervention. Thank you for watching. And if you have any questions, please reach out to the Aggrastat team for more information. Thank you.